Welcome back. Now, in this video, let's discuss about anti-diuretic hormone, which is also called as ADH or vasopressin. Okay. Now, guys, already we have discussed about the aldosterone. Never ever confuse between aldosterone and anti-diuretic hormone. Okay, almost they looks like the same. See, aldosterone helps in sodium reabsorption. So, aldosterone is a mineralocorticoid helping in the sodium reabsorption. But right now I am discussing about anti-diuretic hormone. So in the name itself it's there, see, anti-diuresis, decreases the urination, decreases the amount of urine production, decreases the urine volume. Okay, sir, anti-diuretic hormone or vasopressin. Now point is, now the anti-diuretic hormone is produced where? Anti-diuretic hormone, most of the students will think it is getting produced from the posterior pituitary. No, it's not produced in the posterior pituitary. This anti-diuretic hormone is produced from a hypothalamus. Okay, here is the hypothalamus. Now in this hypothalamus there are two important nuclei present. Yes, you guys already know this. This is the supraoptic nucleus and paraventricular nucleus. The supraoptic nucleus is going to produce anti-diuretic hormone, and the paraventricular nucleus produces oxytocin. So mnemonic is SOAP. So supraoptic nucleus produces the anti-diuretic hormone, paraventricular nucleus produces the oxytocin. Okay, so don't confuse. Now the production of these hormones, okay, oxytocin as well as the anti-diuretic hormone is happening in the hypothalamus. But both these hormones, they will come, okay, they will come and they are stored in the posterior pituitary. Especially this anti-diuretic hormone, as I am discussing about the anti-diuretic hormone, yes, see, it is produced in the hypothalamus from the supraoptic nucleus. And where it is stored? In the posterior pituitary. It is stored in the posterior pituitary. Now, in this posterior pituitary, this anti-diuretic hormone is stored inside these vesicles. These vesicles are called as herring bodies. Okay, the vesicles which are storing, this anti-diuretic hormone. So these vesicles are called as Herring's bodies. Okay, these vesicles. Okay, actually these vesicles are present at the end of the axonal terminal. Now these vesicles are called as the Herring bodies. So Herring body stores anti-diuretic hormone. Okay, now this anti-diuretic hormone, it's going to act on which cells? It's going to act on the principal cells. First of all, where these principal cells we have discussed, the principal cells are present on the collecting ducts. Okay, the principal cells, intercalated cells, they are present on the collecting ducts. Okay, now the anti-diuretic hormone, it will come, it will stimulate the V2 receptors. On these principal cells, there are receptors called as the V2 receptors. Now these V2 receptors are stimulated. See, now the V2 receptors are stimulated by the anti-diuretic hormone. Okay, what happens? Now if the V2 receptors are stimulated, means what happens? Now look at this image, guys. See, now let's start from the story here. This is the distal convoluted tubule or collecting ducts. So both the distal convoluted tubule as well as the collecting ducts, yes, these principal cells are present. Now on these principal cells, yes, see, the V2 receptor is there. Okay, there is this V2 receptor present. Now this V2 receptor is going to be stimulated by the anti-diuretic hormone. The anti-diuretic hormone, it will come and it will stimulate the V2 receptor. My question is, first of all, when do you have this anti-diuretic hormone? When the hell do you need this anti-diuretic hormone? See, imagine you are there in a desert. Okay, you got misplaced from your team in a desert. You went to a desert safari, you got misplaced there. Now what happens? For the entire 24 hours, for the next 24 hours, you are just simply roaming in the desert. Now what is happening? From the sweat, okay, from the sweat, you are losing the water. Okay, so you are having the sweating, so water is going out of your body, so you are suffering with some dehydration. Now you are suffering with the dehydration. Now in this condition, is this a time to produce diluted urine? No, you are not supposed to produce a diluted urine. You need to conserve as much water as possible. Okay, again same story. See, when you misplaced in a hot environment like a desert, now you are sweating, you are getting dehydrated. When you are getting dehydrated, what actually I mean by, your blood volume is shrinking down. Okay, water is going out of your body. So what happened to your blood volumes? Your blood volume is getting concentrated. What happened to your osmolality of your blood? Your osmolality of your blood is increasing. Your blood is becoming hyperosmolar. Okay, now in this condition, are you supposed to produce diluted urine? No, you are not supposed to produce a diluted urine. You need to conserve as much water as possible. So now when your blood is getting concentrated, means now in your blood, concentration is increasing. So this concentration is measured by osmoreceptors. There are these osmoreceptors called as organum vasculosum. Okay, some osmoreceptors are there. Osmoreceptors are present in the central nervous system. Now those osmoreceptors are continuously, okay, they are continuously monitoring what is the blood osmolarity. when your blood osmolarity increases, when your blood is getting concentrated, now this osmoreceptors, okay, now these osmoreceptors, they will be stimulated, okay, they will be stimulated. Now when they stimulate, now these osmoreceptors are going to release, okay, now they are going to help in release of the antidiuretic hormone, okay. Now the osmoreceptors, they will stimulate the pituitary gland, especially they will stimulate the posterior pituitary to release antidiuretic hormone. Now that's how antidiuretic hormone is coming. Now what this antidiuretic hormone is going to do? Now this antidiuretic hormone is going to come and act on the V2 receptors. Now what will happen, sir? Now when the V2 receptors are stimulated, means see, now under the influence of antidiuretic hormone, V2 receptors are stimulated. When the V2 receptors are stimulated, now in these cells, now new proteins are synthesized, okay, new proteins are synthesized. Now what are those new proteins? They are nothing but the water channels, okay, they are the water channels. So new proteins are synthesized here. Now those new proteins will coming, now they are coming and they are getting implanted on the luminal membrane. So this is the luminal membrane, right? Now onto this luminal membrane, now these new water channels are coming and getting implanted over there. Now what they will do? Now under the influence of antidiuretic hormone, now they will start to reabsorb the water, okay, now water reabsorption is happening. So antidiuretic hormone, by acting on the last part of the nephron, helps in water reabsorption. Point is, see, now the water reabsorption is happening here under the influence of a hormone, So this type of water reabsorption is called as facultative water reabsorption. So facultative water reabsorption is due to which hormone? Facultative water reabsorption is due to antidiuretic hormone, okay. Now facultative water reabsorption happens where? In the collecting ducts, facultative water reabsorption happens. And now this type of water reabsorption, see, there is no sodium reabsorption. See, only pure water is getting reabsorbed. See, even aldosterone. See, aldosterone helps in reabsorption of the sodium. So, wherever sodium goes, water reabsorbs. Okay, even aldosterone also helps in little amount of water reabsorption. But that is solute mediated. Solute reabsorption followed by water reabsorption. But this is solute free water reabsorption. See, no sodium is getting reabsorbed. Purely water is getting reabsorbed. So this is an example of solute free water reabsorption. So if someone comes to you and asks you, solute free water reabsorption happens in collecting ducts under the influence of antidiuretic hormone. Antidiuretic hormone stimulates which receptors? V2 receptors. Stimulation of V2 receptors helps in production of which channels? Aquaporin 2 channel. The name of these water channels are called as aquaporin 2 channels. Okay, done. Now you know what is the mechanism of action of antidiuretic hormone. Now after this, let's see what are the important points about the antidiuretic hormone, what are the receptors and where they are present and what are their functions. We'll see one by one. Okay, so antidiuretic hormone is also called as vasopressin. You already know this. See, usually the collecting duct is impermeable to water. So last part of nephron, usually no water reabsorption happens. Okay, normal physiologically no water reabsorption happens. But in special conditions, like you got misplaced in the desert, your blood is getting concentrated, you are getting dehydrated, water loss is there. Now in these conditions what happens? See, usually collecting duct is impermeable to water, but under the effect of antidiuretic hormone, okay, whenever you are dehydrated, whenever your blood osmolality increases, whenever the osmoreceptors are stimulated, now what happens? Now antidiuretic hormone is produced. Now under the influence of antidiuretic hormone, the collecting duct is permeable. Now it is permeable to water. This is called as facultative water reabsorption. Okay, facultative water reabsorption. So by acting on the collecting ducts, it shows solute free water reabsorption. No sodium is getting reabsorbed, only water is getting reabsorbed. Okay, now important point is, see, this antidiuretic hormone, it not only acts on the collecting duct, see, the antidiuretic hormone will also act on the proximal convoluted tubule. Okay, we all know proximal convoluted tubule is a major one who reabsorbs the water. Okay, so major water reabsorption all the time happens in the PCT. So antidiuretic hormone also acts on the PCT. Okay, but usually also, normally also, proximal convoluted tubule reabsorbs 70% of the water. Okay, so if someone asks you under the antidiuretic hormone, okay, under the influence of antidiuretic hormone, greatest volume of water reabsorption happens in PCT. But what is the important point? Usually the collecting ducts, okay, there is no water reabsorption, but under the influence of antidiuretic hormone, now there is facultative water reabsorption or solute free water reabsorption. Okay, done. Now let's talk about the antidiuretic hormone receptors. Okay, important receptors of the antidiuretic hormone. Now antidiuretic hormone have three receptors: V1 receptors, V2 receptors and V3 receptors. Okay, V1, V2 and V3. Now these V1 receptors are also called as V1A receptors, V1A receptors, and these V3 receptors are also called as V1B receptors. Now where exactly these V1 receptors, V2 receptors and V3 receptors are present? Now these V1 receptors, they are present on the blood vessels. Okay, they are present on blood vessels. Okay, now this anti-diuretic hormone, it is coming and acting on the blood vessels. Now when the anti-diuretic hormone is acting on the blood vessel, means what happens? Now the blood vessels will undergo vasoconstriction. That's why vasopressin, anti-diuretic hormone is also called as vasopressin. Why we are calling it as vasopressin? Why? Because it presses the blood vessel. It's a pressor. Like it's a pressor. So blood vessels are going to be compressed like this. So what happens? More BP, more BP. So by acting on the V1 receptors, they will cause vasoconstriction. Okay, they will cause vasoconstriction. So stimulation of V1 receptors will cause vasoconstriction. Done. Okay, that increases the BP. That's not a big deal. Why? Because not much BP is increased. Okay, not much BP is increased. Okay, now where do these V2 receptors are present? Now these V2 receptors are present. Already we have discussed. They are present on the collecting. Okay, they are present on collecting ducts. Okay, now acting on the V2 receptors, now this collecting ducts, they are permeable to water. So more water reabsorption happens. See, water reabsorption happens with the help of which channels? Aqua, porine, 2 channels. With the help of aqua, porine, 2 channels. Okay, done. Now not only that, this V2 receptors, important point, see, they are present on blood vessels. But where? Now in the blood vessels there is endothelium, right? Endothelium. Okay, don't confuse guys. Now V1 receptors are present where? See, this is a blood vessel. I am showing you the cross section of a blood vessel. Now blood vessels are surrounded by what? Now the blood vessels are surrounded by the smooth muscle, right? Now on the smooth muscle, V1 receptors are present. Okay, on the smooth muscle, V1 receptors are present. Now blood vessels, inside them, which lining is present? Now there is this endothelial lining. Now on this endothelial lining, there are these V2 receptors present. So V2 receptors are present where? V2 receptors are present on the endothelial lining. If you stimulate the V2 receptors on the endothelial lining, okay, if you stimulate this endothelial V2 receptors, now this endothelium will start to release von Willebrand's factor. Okay, von Willebrand's factor. Now, for now, just remember that von Willebrand factor helps in platelet adhesion. Okay, that platelet adhesion will be followed by platelet aggregation, followed by the clotting factor activation. So, clot formation. At the end of the day, simple point which I want you to know is normally von Willebrand factor is needed for clotting. Okay, so, or simply saying clot formation. For the clot formation, you need to have the von Willebrand factor. Okay. Now, just remember that point. Later we will understand why this is important. Now, these V3 receptors. Now, where do these V3 receptors are present? Now, these V3 receptors, they are present on the anterior pituitary. Okay, this was the question asked in the exam. Now, when you stimulate the V3 receptors or V1B receptors, now anterior pituitary will release ACTH, adrenocorticotropic hormone. Okay, adrenocorticotropic hormone is released from the anterior pituitary. So, these are the receptors, their locations and their functions. Okay, and their functions. Now, after this, let's discuss about few pathological integrations and pharmacological integrations. Now, in this image, okay, this is an image based question. Now, here, this is an endoscopic view of the esophagus. Okay, this is an endoscopic view of the esophagus where you can clearly see the esophagus is having all these dilated veins. Okay, you can clearly see all these are the dilated veins inside the esophagus. Now, this condition is called as esophageal varices. Esophageal varices means dilated veins in the esophagus. Usually, it is seen as a complication of cirrhosis. Okay, it's seen as a complication of cirrhosis. Whenever there is cirrhosis, the portal pressure, there is portal hypertension. Whenever there is portal hypertension, now all the veins which are draining into the portal veins, like there is more pressure that causes the dilation of the veins. At the end of the day, there is this esophageal varices. Now, if you have this esophageal varices, what happens? Because of the increased pressure inside the veins, they can rupture and they will cause bleeding. Okay, upper gastrointestinal bleeding, they will cause upper gastrointestinal bleeding. Now, how to treat this condition? See, there is esophageal vein dilated. Okay, the esophageal veins, they got dilated. Now, what you need to do? You need to constrict these veins. Okay, you need to constrict these veins. So, you need to do vasoconstriction. So, how can you do the vasoconstriction? See, in pharmacology, there are many ways which you can by which you can do the vasoconstriction. Pressors, lot of pressors are there by stimulating the alpha-1 receptors. But one way to cause this vasoconstriction is stimulation of V1 receptors. Yes, we have discussed that the V1 receptors, they are present on the blood vessels. Now, if you stimulate these V1 receptors, what will happen? The veins will undergo constriction. So, V1 agonists like 𝗏𝐿pressin. Okay, 𝗏𝐿pressin is nothing but an agonist. It's just like vasopressin. Terlipressin is just like a vasopressin or antidiuretic hormone. So that's why it is stimulating the V1 receptors. So this terlipressin is the drug of choice for esophageal varices. Whenever there are these esophageal varices, now in that condition you can use this terlipressin. Okay. Now not only that, remember if there is bleeding esophageal varices, okay, if the bleeding esophageal varices are there, even in that condition you can also use octreotide. Okay, octreotide can also be used in the condition of esophageal varices. Done. Now let's talk about the V2 agonist, stimulation of V2 receptors. When do you want to stimulate the V2 receptors? The V2 receptor stimulation is needed in the conditions like diabetes insipidus. Okay, so in diabetes insipidus and von Willebrand's disease, you have to stimulate the V2 receptors. And who can stimulate the V2 receptors? The drug desmopressin. So desmopressin is going to stimulate the V2 receptors. Now some students will get it out here. So what is this diabetes insipidus? And what is von Willebrand's disease? Okay, von Willebrand's disease. Now for now, see, let's talk about the von Willebrand's disease. Later we will discuss in detail about the diabetes insipidus in the same video. Okay. Now what is von Willebrand's disease? Simple, deficiency of, okay, von Willebrand's factor. Von Willebrand's factor is deficient. When the von Willebrand factor is deficient, platelet adhesion do not occur. Whenever the platelets are not adhesing, platelet aggregation. Okay, platelet aggregation does not occur. So at the end of the day, clots are not going to form. It's not dot, it's clot. Okay, so clot formation is not going to happen. Okay, so clots are not forming. Whenever the clots are not forming, what happens? There will be more bleeding. Okay, so there will be more bleeding. So now tell me, von Willebrand's disease. Okay, von Willebrand's disease is actually a bleeding disorder. Okay, platelets are not like adhesing with one another. Platelets are not no platelet adhesion, no platelet aggregation. So at the end of the day, it's a bleeding disorder. Now what you need to do in this person? See, we know on the endothelial cells, on the vascular endothelial cells, V2 receptors are there. Now if you stimulate these V2 receptors, what happens? If you stimulate these V2 receptors, yes, we know von Willebrand factor is more released, more von Willebrand factor is released. Now if more von Willebrand factor is there, yes, that can actually treat the problem, that can actually decrease the bleeding. So for the treatment of von Willebrand disease, yes, what you need to do, you need to stimulate the V2 receptors by using drugs like desmopressin. Why? Because desmopressin is a V2 agonist. It's a V2 agonist. Okay, now you are having a doubt, sir, what is this diabetes insipidus? Don't worry, we will discuss about the diabetes insipidus in a minute. Now before that, let's discuss about a condition called as SIADH. Okay, SIADH. Now what is this SIADH? SI stands for syndrome. Okay, name is very important, syndrome of inappropriate anti-diuretic hormone synthesis. Okay, so it's a syndrome of inappropriate anti-diuretic hormone or ADH synthesis. Simply we can say, sir, more and more anti-diuretic hormone is getting produced in the body. Unnecessarily more vasopressin or more anti-diuretic hormone is produced in the body. Okay, so it's a little confusing, right? SIADH, SIAD, someone will say it's as SIAD. Syndrome of inappropriate anti-diuretic hormone synthesis, such a big name, right? So simply remember like syndrome of increased ADH, syndrome where anti-diuretic hormone is increased, SIADH. Okay, now question is, why there is excessive amount of anti-diuretic hormone in the body? Okay, why excessive amount of anti-diuretic hormone is there? Usually anti-diuretic hormone should be produced in those conditions whenever the blood concentration increases, okay, or whenever you are getting dehydrated, whenever the blood volume is getting decreased, whenever the blood osmolarity increases. In that conditions, you need to have the anti-diuretic hormone. Okay. Now, why there is anti-diuretic hormone now? Okay. Why there is SIADH? Why? Because see, this anti-diuretic hormone is going to be seen in certain tumors like Kuczynski cell tumor, in carcinoid syndrome, or in oat cell cancer or small cell cancer of the lung. Okay, in small cell cancer. Okay, small cell carcinoma of lung. Now in all these conditions, what happens is, now these tumors, okay, these tumors are unnecessarily producing the anti-diuretic hormone. So you can clearly see this is a lung, okay, this is a lung. Now you are having a cancer, okay, lung cancer. Now this cancer is producing the anti-diuretic hormone. So usually some students get this doubt, sir, how can cancer? See, normally anti-diuretic hormone should be produced from the hypothalamus, hypothalamic neurons, the supraoptic nucleus of the hypothalamus, right? It should be producing the anti-diuretic hormone. Now how come this lung tissue, how come the lung tissue is able to synthesize the antidiuretic hormone? Usually students get this kind of doubts. Okay, usually in your first year you will get this kind of doubts. Say my question to you, we are having billions and billions of cells. Okay, even trillions of cells are there. Now all these cells are having all the 23 pairs of chromosomes are not, all the 23 pairs of chromosomes are there except the germ cells, 23 pairs of chromosomes or 46 chromosomes are there. Now all these 46 chromosomes have all the genes. Now even say my epithelial cells, okay, here are the epithelial cells present. Now even this epithelial cell, skin cell, it contains the 46 chromosomes. Okay, if you take one skin cell, epithelial cell, now inside that epithelial cell there is a nucleus present. Even in that nucleus 46 chromosomes are present, 23 from the mother and 23 from the father. Now all these 46 chromosomes have all the genes or not? Yes, all genes are present. So the genes for my hair color, the genes for my eye color, the genes for my enzymes, the genes of my height, the genes of my color, everything is present in every cell. All the information is present in every cell. Now what is happening? Now this is a cancerous condition. Now the cells got crazy. Okay, now these cells are not going to play according to the rules. Now the cells, they will produce whatever the hormone they want. Now what is happening? Now these cancerous cells, now they will start to produce the antidiuretic hormone. Now what this antidiuretic hormone is going to do? This antidiuretic hormone will powerfully stimulate or continuously stimulate the V2 receptors. So now the V2 receptors are continuously being stimulated. Now what happens? Now all the time 24/7 the cancer is producing the antidiuretic hormone. The cancer is going to the antidiuretic hormones are going to stimulate the V2 receptors. Now the V2 receptors are stimulated means continuously 24/7 see water is getting reabsorbed into the cell. Okay, water is getting reabsorbed into the cell. Now tell me, in the syndrome of antidiuretic hormone synthesis, syndrome of increased antidiuretic hormone synthesis, now what happened to the urine production? What happened to the urine volume? More urine is going to be produced or less urine is going to be produced? Sir, less urine will be produced. Okay, so less urine produced. Why? Because see more water is getting reabsorbed. So never ever say like in syndrome of inappropriate antidiuretic hormone synthesis there is polyuria. No. If you see a question with the polyuria, don't even think about the SIADH. Usually why I am saying this is, usually this disorders, SIADH, diabetes insipidus, usually students will confuse. Okay. So if you see the word polyuria, don't think about SIADH. Okay. In SIADH there is oligouria, less urine production is there. Why? Why? Because most of the water is getting reabsorbed back into the body. Most water is getting reabsorbed back into the body. So what happened to the urine production? The urine is produced less. And that too, what about the concentration of this urine? The urine is hyperosmolar. Okay, the urine is hyperosmolar. Okay, so more concentrated urine. Now my point, see, all this water is getting unnecessarily reabsorbed into the body. So what happened to the volume? What happened to the blood volume? Blood volume increases. Okay, blood volume increases. More and more water is getting into the body. So my blood will become diluted or my blood will become concentrated? My blood will become diluted. Okay, so what happened to the osmolarity of the blood? The osmolarity of the blood decreases. So in SIADH, what happened to the osmolarity of the blood or the plasma? Blood osmolarity decreases. Important point. What happened to the urine osmolarity? Urine osmolarity increases. Okay. Now my question. See, more and more water is coming into the body. So it will dilute the body fluids. So what happened to the sodium concentration inside the body? Sodium concentration inside the body relatively decreases. Why? Because more fluid is coming, right? So that will cause a dilutional hyponatremia. So the person who is having SIADH, he will have dilutional hyponatremia. Okay, dilutional hyponatremia, or I can say decreased sodium concentration. Decreased sodium concentration. Say, it's not the sodium which is going out of the body. No sodium is going out of the body, but more water is coming, right? Okay, more water is coming. If you put more water, it dilutes the sodium. It dilutes the sodium. So it will cause dilution hyponatremia. But what happened to the urinary concentration of sodium? See, more water is getting reabsorbed. So what happened to the urine? Urine has become hyperconcentrated. So what happened to the concentration of the sodium in the urine? So there is concentration of sodium in the urine. So more sodium in the urine. Okay, so more sodium in the urine means it's not the sodium is getting excreted, sodium is getting concentrated because less water is there in the urine. Okay, so these are some important points which I want you to know regarding the SIADH. Now, okay, now see, this patient is coming to you. Okay, imagine. Okay, think that you are a doctor now. Right now, you are sitting in the clinic. Now, this patient is coming to you, and what he is going to complain you? He is going to complain you that he is producing very less urine. Okay, oligouria is there. Now, when he says that he is producing very less urine, now what is that first thing that you are coming to your mind? You might be thinking that, okay, this fellow is not drinking proper water. Okay, this fellow is not drinking proper water. So, if there is decreased urine output. Okay, now it might be two reasons. There might be two reasons. One reason is this patient is this patient is having decreased water intake. Okay, you are thinking that, okay, this patient is having decreased water intake, that's why he is producing the less urine. Or this may be because of SIADH. So these are the two reasons why the patient might be producing the less urine. So how to differentiate? Okay, how to differentiate? See, how to differentiate is by water loading test. Now you are going to ask the patient to stay in the hospital. Now you are going to ask this patient to take more water. You are loading this patient with the water, and you are going to check the urine output. Now in a healthy individual, for example, if the individual is healthy, if you take water, if you take lot of water, automatically your urine output increases. Now for example, if this patient is having less urine output because of less water intake, now when you give water, automatically his urine output is going to be increased. Okay, his urine output increases. But right now our patient is having SIADH. Now whatever the water you give, okay, you give him 2 liters of water, 3 liters of water, 4 liters of water, doesn't matter. He is having high levels of anti-diuretic hormone. This high levels of anti-diuretic hormone, what it will do? It will reabsorb all the water. So water is not coming out in the urine. Okay, water is not coming out in the urine. So urine is again still, even though you are putting more water into his body, his urine will be hyper concentrated. Okay, so what is the investigation of choice? The investigation of the choice for the SIADH is water loading test. Okay, never answer it as water deprivation test. Water deprivation test we will see in a minute. So water loading test is the investigation of choice. And look at the laboratory. Just now we have discussed urine osmolality increases, hyper concentrated urine. What about the blood osmolality? More water going back into the blood. So what about the plasma osmolality? Plasma osmolality decreases. What about the sodium levels in the blood? The sodium levels in the blood are going to be diluted. So dilutional hyponatremia is there. Dilutional hyponatremia is there. Now how to treat these patients? Okay, how to treat these patients? Treatment is very simple. Now actually you have to treat the cancer, but that's not going to be done that easily, right? Okay. Now what you need to do? Okay, let the anti-diuretic hormone is there. Okay, let the anti-diuretic hormone, it will be there. Now simply come and block the receptors. Okay, simply come and block the V2 receptors. If you can block the V2 receptors, now the anti-diuretic hormone, it cannot act there. Okay, so treatment of SIADH is, symptomatic treatment is Vaptons. Vaptons, what are the examples of Vaptons? Tolvaptan, Conivaptan. Okay, Vaptons. So Vaptons are nothing but the V2 blocker, V2 receptor blockers. If you block the V2 receptors, automatically the symptoms will be treated. So with this, we are done with the topic of SIADH. Now let's discuss about diabetes insipidus, guys. Now let's discuss about the diabetes insipidus. So what is this diabetes insipidus? See, as a doctor, whenever you see this word diabetes, okay, diabetes, see, don't think that diabetes, sir, hyperglycemia. No, in this condition there is no hyperglycemia. Diabetes means more urination. Okay, this should come to your mind. Diabetes means more urination. There are different types of diabetes, diabetes insipidus, diabetes mellitus. Okay, but here the problem is diabetes insipidus. More urination is there, diabetes. And what about the type of urine? This urine is insipid. Insipid means, exact meaning is tasteless. Tasteless urine. Why it is tasteless? See, the exact thing what, like, the author want to say, the one who, keeps this name, the one who gives this name, diabetes is excessive urination is there, more urination is there. And this urine is not having any taste, which means sodium is not there. If there is sodium will give the salt taste, right? Now in this patient, the urine is not having the salts. The urine is not having the sodium in it. So that's why diabetes insipidus. Okay, now what exactly is happening is diabetes insipidus? Simple. The diabetes insipidus, the patient is not having antidiuretic hormone. Simply try to understand it like this. Whenever there is no antidiuretic hormone, what happens? Okay, whenever there is no antidiuretic hormone, no water reabsorption. Okay, no water reabsorption is happening. Okay, so whenever there is no antidiuretic hormone, no water reabsorption, no aquaporin 2 channels, no water reabsorption. Whenever there is no water reabsorption, the water which was supposed to be reabsorbed, now it is going out in the urine. Now what happened to the urine? More volume of urine. This patient is producing more and more volumes of urine. So that's why diabetes. Urine, more urine there, right? So what happened to the sodium levels in the urine? Diluted away. So insipid, less salts are there. Okay, not concentrated urine, diluted urine. Now let's talk about what are the causes of diabetes insipidus. Okay, why there is this diabetes insipidus. Okay, see, before going to the causes, simply try to understand. There is no antidiuretic hormone, no water reabsorption. Whenever there is no water reabsorption, all the water is going into the urine. So more urine is getting produced. So there is polyuria. So whenever you see a case of a polyuria, think about diabetes insipidus, DI, not about SIADH. In SIADH, the patient is going to have oligouria, very less urine production, hyper concentrated urine there. Okay, more salts are there in the urine there. Now in this condition, diabetes insipidus, more urination, diluted urine. Okay, less concentration of the urine, not less urine, less concentration of the urine. Okay, less sodium levels are there in the urine. So polyuria, think about diabetes insipidus. Now let's talk about the causes of diabetes insipidus. Now the causes are two types. Diabetes insipidus, it's of two types. One is central diabetes insipidus. What is central diabetes insipidus? Some problem in the central nervous system. And the other is nephrogenic diabetes insipidus, some problem in the nephron. Now let's start with the central diabetes insipidus. Simple. Normally we all know antidiuretic hormone is produced from the hypothalamus. It is stored in the posterior pituitary. Now if there is any damage to hypothalamus or pituitary, simple, damage to hypothalamus or pituitary gland, now no antidiuretic hormone is there. Whenever there is no antidiuretic hormone, what happens? More urination. So this is central diabetes insipidus. Now the patient is not having antidiuretic hormone, enough amount of antidiuretic hormone, so more urination. How to treat this condition? If the patient is not having antidiuretic hormone, you give the antidiuretic hormone or give antidiuretic hormone analogs like desmopressin. So desmopressin is like vasopressin. Desmopressin is nothing but the antidiuretic hormone which is made in the pharmacy. So intranasal desmopressin, intranasal desmopressin is used in the treatment of central diabetes insipidus. So this is the drug of choice for central DI. Now what is nephrogenic diabetes insipidus? In nephrogenic diabetes insipidus, there is no problem with the center. Okay, there is no problem with the central nervous system. Central nervous system is producing the antidiuretic hormone. Okay, central nervous system is producing the antidiuretic hormone. But this antidiuretic hormone, it's it's not stimulating the receptor. Why? Because the receptor is mutated. The V2 receptors, they are resistant. Okay, so now the V2 receptors are mutated. So antidiuretic hormone is there, but the V2 receptors are non-functional. If they are non-functional, it looks like antidiuretic hormone is not there. Okay, antidiuretic hormone is there, but it is useless because it cannot stimulate the V2 receptors. Okay, now if you ask me why these V2 receptors are not functioning, there is some problem in the nephrons. Because of that, the V2 receptors are not functioning. So what are these nephronal problems? Like lithium, using of these drugs like lithium. Okay, lithium is a mood stabilizer. Okay, especially used in bipolar disorder, schizophrenia. Okay, now this lithium, what it will do? Whenever you take this lithium is a nephrotoxic drug. It will cause V2 receptor resistance. Or taking drugs like amphotericin B. Okay, amphotericin B. Or conditions like amyloidosis. So drugs and conditions like amyloidosis will cause V2 receptor resistance. V2 receptor not functioning, no water reabsorption. No water reabsorption, all water is going out in the urine. That will cause us polyuria. Okay, now how to treat this condition, sir? Now he is having polyuria, right? Now in this condition, yes, the drug of choice are going to be thiazide diuretics. Especially we are going to use the thiazide diuretics. Okay, thiazide diuretics are the drug of choice. I am not going in detail how exactly the thiazide diuretics are going to decrease the urination. But you will study this in your pharmacology. Just from my side, I am saying that thiazide diuretics are the drug of choice for treating the nephrogenic diabetes insipidus. For example, if it is craniogenic diabetes insipidus, it is desmopressin. Okay, now look at the labs. Sir, in diabetes insipidus, what are the labs? Now polyuria, right? So what about the urine osmolarity? Polyuria, more urine, more water is going out in the urine. So urine will be concentrated or diluted? Diluted urine. So urine osmolarity or urine concentration is decreased. What about the plasma osmolarity? All the water is going out of the body in the form of urine. So blood volume decreases. Blood is getting concentrated. So what about the plasma osmolarity? Plasma osmolarity increases. Okay, plasma osmolarity increases. What about the sodium concentration in the body? See, all the water is going out of the body. Okay, all the water is going out of the body. So sodium inside the body is getting concentrated. So sodium concentration increases. Sodium concentration increases in the plasma, but sodium concentration decreases in urine. Okay, in the urine, sodium concentration decreases. Okay, sodium is getting diluted away. That's why insipidus, no salts. Okay, no salts. Okay, now in clinic, if the patient, think like as a doctor. Now a patient is coming to you. Okay, now a patient is coming to you. Now he is giving this one complaint. He is saying, doctor, I am producing more urine. Okay, I am producing more urine. He is saying, I am going to do this urination almost 20 times a day, for example. Now you might be thinking, okay, this patient might be having some psychological abnormality. He is drinking so much amount of water. Actually, there are these cases which is called as psychogenic polydipsia. There is this one case called as psychogenic polydipsia where the patient is continuously drinking water. Okay, lots and liters of water he is drinking. Now when he drinks more water, automatically more urine will be produced. Okay, so if he is coming and saying you that, doctor, I am producing more amount of urine. Okay, more amount of urine. Now the first thing that comes to your mind is that, okay, maybe this patient is drinking more water, that's why he is producing more urine. So let's draw something like this. Whenever the patient is having polyuria, okay, whenever the patient is having polyuria, now what are the two possibilities? The two possibilities may be psychogenic. Okay, polydipsia. Okay, psychogenic polydipsia, or it can be because of diabetes insipidus. In both the conditions, the patient is going to have polyuria, more urine production. Okay. Now, how to differentiate? See, ask this person to stay in the hospital. And don't give any water to this patient. That is water deprivation. You are not giving any water to this patient. For example, if this is a case of, psychogenic polydipsia. Now this patient is not drinking the water. Now if he doesn't drink the water, automatically his urine output decreases. The number of time he will go for the urination decreases. So everything comes back to normal. So in the case of psychogenic polydipsia, the urine now it will start to concentrate. Now he will start to produce the concentrated urine. Why? Because you are not giving the water. So now he will start to produce the concentrated urine. But if it is a case of diabetes insipidus, what will happen? Now, even though you are not giving water, okay, you are not giving the water, but still he will produce diluted urine. Okay, he will produce large amount of urine. Why? Because he is not having anti-diuretic hormone. Whenever the anti-diuretic hormone is not there, now he is producing excessive amount of urine. So this is how to differentiate between psychogenic polydipsia as well as diabetes insipidus. Okay, so the investigation of choice is water deprivation test. Now see, in diabetes insipidus, what about the urine osmolarity? Urine osmolarity decreases. What about the plasma osmolarity? Plasma osmolarity increases, concentration. What about the sodium concentration in the plasma? Sodium concentration in the plasma increases. Why? Because loss of water. Okay, loss of water from the body. So sodium is getting concentrated in the plasma. Okay, plasma osmolarity increases, plasma is getting concentrated, blood volume shrinks, blood volume is decreasing, blood volume is getting concentrated. What about the urine? More urine, right? More urine means the concentration of the urine is decreasing. So osmolarity, urine volume is more. When you have more urine, it is less concentrated. So urine osmolarity decreases. So please see, in SIADH, in diabetes insipidus, there are these differences present. Okay, there are these differences. So based on these differences, we will differentiate between SIADH and diabetes insipidus, the two important clinical cases which you need to know for your exam. Okay, very important for your exam. So with this, we are done with the topic of anti-diuretic hormone, and also we have seen some important clinical integrations. Okay, hope the video is helpful. Thank you.